All right, everyone, get ready for this. We're going deep into some ophthalmology today, and you guys sent in some really interesting cases. So we're going to kind of walk through them like you're in an oral exam.
Yeah.
So think of this as like your prep session, right? Hoping you connect the dots, really sharpen up those diagnostic skills.
I'm excited to break down these cases with you. It's not just about getting to the right answer, but it's really understanding, the why behind it all.
Exactly. And to help us navigate this whole journey through diagnosis, we have a fantastic ophthalmologist here with us today with years of experience. Welcome to the show.
Thanks for having me. Excited to jump into these cases.
Perfect. Let's start with a picture that really caught my eye.
Yeah.
This is an image of an eye that's clearly had some surgery. The most prominent feature is this raised area, almost like a blister. What procedure are we looking at here, and what exactly was done surgically to create this?
Right. So this is a post-operative image showing what we call a filtering bleb. And the procedure that was performed here is a trabeculectomy. So imagine you need to create a new drainage channel in the eye to lower the pressure. So trabeculectomy does just that. It creates a passage between the anterior chamber, which is the fluid-filled space in front of the iris, and the subtenon space, which lies beneath the conjunctiva. So that's that clear membrane that covers the white part of your eye.
Okay. I get why it's called a filtering bleb now.
Yeah.
But why does it have this raised, almost bubble-like appearance?
So yeah, you're right. To focus on that appearance, the bleb itself forms as aqueous humor, which is that fluid inside the eye flows into this newly created space. So think of it like a tiny reservoir under the conjunctiva. Now that raised appearance can be due to a couple of things. Sometimes there are engorged blood vessels in the surrounding area, so that adds to the elevation. And other times it can be related to the use of medications called antimetabolites during the surgery, which can kind of affect tissue healing and contribute to that bubbly look.
This all makes sense, but I can't help but think about, what could go wrong? What are some of the things that could go wrong with a filtering bleb?
Yeah, that's an excellent question, and it's a crucial consideration for any ophthalmologist. And one of the most common concerns is bleb failure. So imagine the bleb is like this delicate valve. If scar tissue forms around the bleb, what we call subconjunctival fibrosis, it can block that drainage pathway and lead to bleb failure, and that's where postoperative management is so important.
So if we see a patient with bleb failure, what are our options? Do we always have to go back in surgically?
Not necessarily. We have a range of tools at our disposal, both non-surgical and surgical if it's caught early. Sometimes simple things like applying gentle pressure, what we call digital massage, or using an instrument to kind of manipulate the area, we call that scleral depression, can help. We can also inject medications like 5-FU under the conjunctiva to help break down that scar tissue.
So it's almost like we're giving a little tune-up.
Exactly.
But I know sometimes we do need to use lasers in postoperative care. Are there specific lasers used after a trabeculectomy, and what do they do?
Absolutely. Lasers can be incredibly valuable tools in this setting. One laser we use often is the NDAG laser. Think of it like a microscopic scalpel. We can use it to create a small opening in the bleb to help with drainage or even to remove blockages at the internal opening of what we call the fistula, that channel that we created earlier. And often we'll use specialized lenses like a Hoskins or Zeiss lens to focus that laser energy precisely where we need it.
So it's not just about using a laser, but using the right laser and technique for the job. What about the argon laser? Does that have a role here?
It does. The argon laser is particularly helpful for a procedure called laser suture lysis. So during a trabeculectomy, we sometimes use sutures to control the flow of aqueous humor. And later on, we can use the argon laser to carefully loosen or release those sutures, allowing for more drainage if needed. It's a way to fine-tune that bleb function over time.
Makes so much sense. So we've covered the what, the why, and even the how of dealing with a filtering bleb. It's amazing how much goes into managing just this one post-surgical structure.
It really does highlight the complexity of ophthalmic surgery and the need for, careful individualized care. Now, let's shift gears and move on to a different type of image.
All right, let's get visual. We have a visual field test in front of us, and the key feature here is this prominent dark spot right in the center, what we call a scotoma. What type of scotoma are we looking at here? What should that tell us?
So this is what we call a centro-caecal scotoma. And notice how it involves the central vision and extends towards the blind spot, which is that area where the optic nerve exits the eye. And this particular pattern often points towards a condition called toxic optic neuropathy.
Toxic optic neuropathy. Now that sounds concerning. It makes me think that something is harming the optic nerve. What are the most common culprits behind this condition?
You're right on the mark. Toxic optic neuropathy occurs when that optic nerve is damaged by certain substances. And the two most frequent offenders are alcohol And smoking, so excessive consumption of either, can lead to this type of nerve damage.
So it's another reminder of how lifestyle choices could have a direct impact on eye health if we suspect toxic optic neuropathy in a patient. What would our treatment strategy involve?
So the first and most crucial step is to eliminate the offending agent. So we need to advise the patient to stop smoking and drinking alcohol completely. Alongside that, we can administer injections of hydroxocobalamin, which is a form of vitamin B12, for about 10 days to help nourish and repair that damaged nerve. And of course, a healthy, balanced diet rich in protein is also crucial for recovery.
So essentially, we're trying to support that nerve's natural healing process now. Besides the visual field test, which clearly showed that central scotoma, what other tests would be helpful in evaluating a patient with suspected toxic optic neuropathy?
Good question. We want to get a comprehensive picture of the patient's visual function. So in addition to visual field testing, we'd also perform color vision testing. Toxic optic neuropathy can often affect color perception, particularly the ability to distinguish between red and green. We'd also carefully examine their pupils to see how they react to light, as abnormalities in pupillary responses can be another clue. And finally, we'd assess their near vision to see if there's any impairment in their ability to focus on close-up objects.
So we're gathering information from different angles to see how this condition is impacting their overall vision. Before we wrap up this case, I'm curious, what would we expect to see if we look directly at the optic nerve of a patient with toxic optic neuropathy?
Great question. So during an ophthalmoscopic exam, we'd likely see some telltale signs. The optic disc, which is the head of the optic nerve, might appear pale, especially on what we call the temporal side. We might also observe mild swelling, or what we call edema of the disc, and sometimes there can be these tiny splinter-shaped hemorrhages. So those are little bursts of blood vessels visible on or around that optic disc.
Okay, so we've got those key signs to look for temporal pallor edema and potentially splinter hemorrhages. It's fascinating how each piece of the puzzle, from the patient's history to the specific findings on different tests, helps us paint a clearer picture of what's going on in the eye. I feel like we've covered a ton of ground already, but before we move on to the next set of cases, let's take a moment to process all this information and really let it sink in.
That's a great idea. It's important to consolidate our knowledge before tackling more challenging scenarios. We'll be back soon with more cases and more insights to help you ace your exams.
All right, everyone, take a breather or grab a coffee, and we'll be back shortly to dive into more exciting cases. Welcome back, everyone. I hope you had a chance to let all that information from our first round of cases sink in. Now we're going to step things up and really put those diagnostic skills to the test.
Get ready for some curveballs. Ophthalmology is all about recognizing these subtle patterns and thinking critically to arrive at the right diagnosis.
Exactly. So let's jump right into our next challenge. This time we have another post-surgical eye. And I want you to take a close look at this image and tell me what you see.
All right, take your time, examine the details, and think about what procedure might have been performed here.
Okay, so I'm seeing what looks like a filtering bleb, but it's different from the one we discussed earlier. This one's much flatter, and the surrounding tissue seems more vascularized, almost like a network of fine red lines.
That's a very astute observation. You're picking up on some key differences here. Now, remembering our discussion about trabeculectomy complications, what could be happening in this case?
Well, we talked about bleb failure due to scarring. Could this be an example of early bleb failure, where the scar tissue is preventing the bleb from forming properly?
That's certainly a possibility, but what other factors could contribute to this less prominent, flatter bleb appearance? Think about the surgical technique itself.
I remember you mentioning the use of antimetabolites during surgery. Could it be that a less aggressive approach with those medications resulted in a flatter bleb?
Precisely, you've hit the nail on the head. The amount and type of antimetabolites used can significantly influence the bleb's appearance. A less aggressive approach might lead to less scarring, but also a less prominent bleb.
So it's a balancing act between preventing scarring and achieving adequate bleb formation. Now, let's say this patient comes back for a follow-up appointment and reports experiencing some leakage from the bleb. What would be your initial approach?
Leakage is definitely a red flag, and we need to act quickly to prevent potential complications like infection. Remembering our discussion about non-surgical bleb management, what options come to mind?
Right, we talk about digital massage and scleral depression. Could those techniques help seal the leak?
They absolutely can, especially if it's a small early leak. It's like gently coaxing those tissues to close that opening. But let's say those conservative measures don't do the trick. What other options would you consider?
Well, I recall you mentioning injections of 5-FU to help break down scar tissue. Could that be an option here, even if the bleb isn't failing due to excessive scarring?
You're thinking strategically. While 5-FU is often used to address scarring, It can also help promote healing and potentially seal a leaky bleb. It's a versatile tool in our arsenal, but what if, despite all these interventions, the leakage persists?
Then I'm guessing surgical intervention might be necessary to revise the bleb and ensure proper drainage.
Exactly. It's important to recognize when conservative management has reached its limits and a surgical approach is required. So as you can see, even a seemingly straightforward filtering bleb can present a wide range of challenges. It all comes down to careful observation, understanding the underlying mechanisms, and tailoring your approach to the individual patient.
It's like being a detective, piecing together clues from the bleb's appearance, the patient's symptoms, and our knowledge of potential complications to come up with the best course of action. I'm starting to feel more confident in my ability to think through these cases.
That's what we want to hear. Now, you mentioned lasers earlier. I'm curious, how do you see those fitting into the management of bleb leakage?
I remember you saying the N.YAG laser can act like a microscopic scalpel. Could we use it to create a controlled opening in the bleb wall to allow for drainage and relieve pressure?
That's brilliant. You're absolutely right. We can use that N.YAG laser to create a small intentional perforation in the bleb to allow for controlled drainage. This can be a very effective way to manage leakage and prevent further complications.
So lasers aren't just for cutting and sealing, they can also be used for precise fluid management. It's amazing how versatile these tools are in ophthalmology.
Ophthalmology is a constantly evolving field. New technologies and techniques emerge all the time, which is why it's so important to stay curious and keep learning.
But I have to admit, I'm still a bit curious about the visual field testing for glaucoma.
Yeah.
You mentioned using blue targets on a yellow background. Why that specific color combination? Is it just to make the test more interesting?
Not quite. It's actually all about targeting specific cells in your eye. You see, the retina, that light-sensitive layer at the back of your eye, contains different types of what we call photoreceptor cells. Some are responsible for detecting color, while others are responsible for detecting light and dark. The blue-yellow color combination specifically targets a type of what we call cone cell that is particularly vulnerable to damage in those early stages of glaucoma.
So it's like we're using a special type of bait to fish for early signs of glaucoma. I love that analogy.
Yeah.
So if we see those telltale blue-yellow visual field defects, what happens next? What are the goals of glaucoma management?
That's a great question. The ultimate goal of glaucoma management is to preserve the patient's vision. We do that by slowing or halting the progression of the disease. And the key to achieving that is early detection and intervention. Typically, we manage glaucoma by lowering intraocular pressure. That's the pressure inside the eye, which can damage the optic nerve over time. And we have a variety of tools at our disposal to achieve this, including medications, laser therapy, and even surgery.
So it's a multifaceted approach tailored to the individual patient's needs and the stage of their disease.
Mm-hmm.
Okay, we've tackled filtering blebs, OCT interpretation, and even touched on visual field testing for glaucoma. But I know there's always more to learn. What other diagnostic tools should every aspiring ophthalmologist be familiar with?
Well, we've talked about ophthalmoscopy, which allows us to look directly into the eye and examine the structures at the back of the eye. But there's much more to it than just a basic exam. You'll need to master techniques like indirect ophthalmoscopy, which gives you a wider field of view, and slit lamp biomicroscopy, which uses a high-intensity beam of light to examine the eye in detail, and of course fluency in interpreting various imaging modalities like fluorescein angiography, which highlights the blood vessels in the eye, and ultrasound, which can help us visualize structures that are difficult to see with other methods, is essential.
Wow, it's like becoming a detective of the eye, piecing together clues from all these different sources to arrive at a diagnosis. But even with all these tools, I imagine clinical judgment and experience still play a huge role, right?
Absolutely. Technology can provide invaluable insights, but it's that human element, the ability to listen to the patient, observe subtle signs, and integrate all the information that ultimately leads to accurate diagnosis and effective treatment. That's why lifelong learning and continuous professional development are so crucial in ophthalmology. We're always striving to refine our skills and stay at the forefront of our field.
This deep dive has been incredible so far. I'm excited to see what other challenges await us in our final set of cases.
Get ready for some thought-provoking scenarios.
We're back for the final part of our ophthalmology deep dive today. I'm ready for some more cases.
Let's do it. Let's test out your diagnostic skills one last time.
Bring it on. I'm ready.
All right, let's go back to a topic we talked about earlier, visual field defects. Remember that case with the centro-caecal scotoma that pointed towards that toxic optic neuropathy?
Yeah, absolutely. That one really stuck with me.
Yeah.
It's so important to think about those lifestyle choices.
Exactly. Now, Imagine a similar scenario. You've got a patient who's coming in with vision problems. We do a visual field test. But this time, instead of that central scotoma, we're seeing this dense arcuate scotoma, and it respects the horizontal midline. What would that make you think of?
An arcuate scotoma respecting the horizontal midline. That's making me think glaucoma is specifically damage to those nerve fibers in either the superior or inferior part of the optic nerve head, like a band of vision loss that follows that curve of the optic nerve fibers.
You're making those connections between the visual field defects and what's going on underneath. How would you differentiate between that glaucomatous damage and other things that could cause an arcuate scotoma?
Okay, so first things first, I want to get a good history from the patient. You know, the diabetic, is there a family history of glaucoma? Then I check their intraocular pressure. Obviously, that's a big risk factor. And of course, a thorough exam of the optic nerve head using ophthalmoscopy.
Yeah.
What would we be looking for? Are there any specific signs that would point towards glaucoma? You're on the right track. There are some telltale signs in glaucoma. You often see what we call optic disc cupping. The optic disc is that pale circular area where the optic nerve enters the eye cupping. Means we're seeing an enlargement of that central depression within the disc, a sign that those nerve fibers are being lost. You might also see nasalization of the retinal vessels. That means those blood vessels look like they're shifted towards the nasal side of the optic disc.
Okay, cupping, nasalization. Got it. What if those findings are kind of tough to interpret? Are there any other tests that could help us confirm or rule out glaucoma?
For sure, imaging can be super helpful here. OCT, optical coherence tomography, can give us really important information in those situations. OCT can still pick up on subtle thinning of that retinal nerve fiber layer, which would make us think glaucoma.
So OCT helps us see things we might miss with ophthalmoscopy alone. What if, even with OCT, things are still fuzzy? Are there any other tools we could use? Yep. In those tough cases, we might do a test called visual evoked potentials, or VEPs. This measures those electrical signals from the brain in response to visual stimuli if the optic nerve is damaged. Those signals can be delayed or abnormal, and that helps us figure out if it's glaucoma or something else.
That's wild. It's amazing how we can assess the whole visual pathway from the eye all the way to the brain. The real trick is knowing when to use which tool and then putting all that information together to make the right call.
Exactly. Ophthalmology isn't just about memorizing facts. It's about using, being a critical thinker and being flexible. Each patient is different, and we have to adjust our approach for each one.
This deep dive has been awesome.
Yeah.
I feel so much more prepared to approach these cases now. Any final wisdom for all those aspiring ophthalmologists out there?
Never underestimate the power of observation, both during the exam and when you're looking at those test results. Pay attention, ask questions, and never stop learning. Ophthalmology is always changing. There's always something new to learn.
That's great advice. Huge thanks to you for walking us through these cases and for sharing your expertise. And to all of you listening out there, thanks for joining us on this deep dive into the world of ophthalmology. We hope you enjoyed it and that you feel more confident in tackling these kinds of cases. Keep those eyes healthy and those minds sharp. We'll see you next time.